Good morning. It's a special presentation about diabetes and renal transplantation for both recipients and the risk of diabetes after kidney donation. I'm going to start with a small introduction, then the focus of the presentation will be on post-transplant diabetes. I'm not going to discuss the pre-existing diabetes and its management, but I am stressing upon the newly developed diabetes after kidney transplantation, so I'll give a hint about its definition and diagnosis, epidemiology, risk factors for its development, how to manage and its impact on transplantation outcome, and then the Mansoura Urology and Referral Center experience in the field of post-transplant diabetes, and I'll end with the most exciting sector, which is the kidney corner, the kidney donor corner. To start with the introduction about the relation of diabetes and end-stage kidney disease, as you see, the most common causes of end-stage renal disease worldwide and in the United States specifically, because this is the last report of the United States Renal Data System, showing that diabetes is the leading cause of end-stage kidney disease, followed by hypertension, glomerulonephritis, and polycystic kidney disease. And if you focus on diabetes, you find increasing prevalence of diabetes through the years in the United States as a cause of end-stage kidney disease. The presence of diabetes as original kidney disease adversely affects transplantation outcome in living donor kidney transplantation and in cadaveric kidney transplantation arenas. As you see here, this is a color code of diabetes. The graft survival is adversely affected by the presence of diabetes in both living and cadaveric transplantation. This is maybe due to patient adversely affecting diabetes adversely affect the patient's survival. What about post-transplant diabetes, newly developed diabetes after kidney transplantation? This is the last proceeding from an international consensus meeting on post-transplantation diabetes, including 7 recommendations. The first recommendation is this consensus stressed upon the changing terminology from the new onset diabetes after transplantation. Know that this terminology was used frequently, back to the old one, which is post-transplant diabetes mellitus. This is a cross-sectional study, included 889 patients for the first kidney transplant candidates, and this is very interesting because when they followed oral glucose tolerance for these patients before transplantation, especially for patients with fasting plasma glucose ranging between 92 and 125, they discovered undiagnosed cases of diabetes. This is why using post-transplant diabetes is better than saying new onset diabetes after transplantation. How to diagnose post-transplant diabetes is by following any of these 4 values. Fasting glucose exceeding or equal 126 milligram per deciliter, 7 millimole per liter, on more than one occasion. Random glucose, plasma glucose, equal or exceeds 200 milligram per deciliter, 11.1 millimole per liter, with presence of diabetic symptoms. 2-hour glucose after a 75 gram oral glucose tolerance test equals or exceeds 200 milligram per deciliter, 11.1 millimole per liter, or hemoglobin A1C equal or exceeds 6.5%. But be careful, because hemoglobin A1C shouldn't be used alone to screen for diagnosis of post-transplant diabetes within the first year after transplantation, and its use within the first 3 months is useless because of the presence of commonly anemia in this period of time, and after transplantation there is a time for stability of hemoglobin. So it's better not to use at all hemoglobin A1C post renal transplantation for 3 months, and not to be used alone during the first year after transplantation. This is one of the studies that showed limitation of hemoglobin A1C. Here, even if we use cutoff point of 5.5%, that increases the sensitivity for diagnosis of diabetes, but again, specificity and the post-predictive value are low. So there is a major limitation for the successful use of hemoglobin A1C after kidney transplantation. This is another study including 83 patients, and it concluded that fructosamine may be more accurate diagnostic test, but this needs to be further examined in large cohorts of patients. So what about the diagnosis? Diagnosis of post-transplant diabetes is dependent upon the onset of hyperglycemia and its persistence. If it is restricted only to the first 45 days, 1.5 months, or 6 weeks after transplantation, it is not enough to diagnose post-transplant diabetes, but we can say transient post-transplant hyperglycemia. But if it occurs beyond this zone of time and it persists, it is post-transplant diabetes. If we want to diagnose the post-transplant diabetes in this period of time, it's better to use oral glucose tolerance test, fasting and random glucose, and hemoglobin A1C. But after a year, we can use oral glucose tolerance test, hemoglobin A1C, fasting or random glucose, because hemoglobin A1C alone within the first year, before the end of the first year, will underestimate the presence of post-transplant diabetes and needs supporting evidence for diagnosis of diabetes. Again, look at the time onset of hyperglycemia. If it is before 1.5 months, this is hyperglycemia. If it's beyond this, it is diabetes. What about the epidemiology of post-transplant diabetes? If we look at the United States Renal Data System, this is a percentage of adult deceased donor kidney recipients who were non-diabetic at the time of transplantation and developed post-transplant diabetes. And post-transplant diabetes is reported on the transplant recipient follow-up form. And if you look here, this is the color code for diabetes during the first year, 3 years, and 5 years after kidney transplantation. This is a retrospective cohort study that was performed at the outpatient clinic of the clinical department of nephrology and dialysis of the Medical University of Vienna. The kidney transplant recipients, after 6 months of transplantation, were routinely assigned to 2-hour oral glucose tolerance test, and their data were analyzed in the context of the transplant-associated hyperglycemia. So it is an open, non-interventional, observational cohort study which has been published previously. Impaired glucose tolerance was defined as 2-hour plasma glucose of 140 to up to 199 milligram per deciliter during the oral glucose tolerance, and the impaired fasting is fasting glucose of 100 to 125 milligram per deciliter. All patients with newly diagnosed post-transplant diabetes defined by 2-hour equal or exceeds 200 milligram per deciliter, and this is the data. If you look here, normal glycemia is witnessed in approximate 60% of the patients. However, post-transplant diabetes was diagnosed in 12.5%. Impaired fasting glucose is diagnosed in 12%. Impaired glucose tolerance in 7%, and combined impaired fasting and impaired glucose tolerance in 8.9%. Again, this is another study including 481 patients. The diagnosis of post-transplant diabetes according to the study, was 22.5%. And if we look at the organ transplantation and the incidence of post-transplant diabetes, we can find that the incidence in kidney transplantation is variable between 10 to 74%, in heart transplantation 11 to 38%, in liver transplantation between 7 to 30%, and in lung it is 32%. The most recent data, according to this publication, if you look here, this is liver transplant recipient, and this is a kidney transplant recipient. Metabolic syndrome is present in 41% at 6 months post-kidney transplantation. Diabetes, post-transplant diabetes or newly diagnosed diabetes after transplantation ranged from 2 to 53% of kidney transplant recipients. Dyslipidemia and hypertension are commonly encountered after kidney transplantation. This is a very interesting study because it included sufficient number of patients. In this study, 672 patients using repeated oral glucose tolerance test. Here, up to 30% of transplant recipients develop post-transplant diabetes mellitus, and another 30% have pre-diabetes, either impaired fasting or impaired glucose tolerance test. If we look at the data, this is the data during the first 3 months. Here, post-transplant diabetes was diagnosed in 30% of patients, pre-diabetes in 28%, and normal glycemia in 39%. If you look at the evolution of post-transplant diabetes, 78% persist after 3 years to be diabetic, 10% it changed into pre-diabetes, and 11% it changed to normal glycemia. And if we look at the evolution of pre-diabetes, 20% of pre-diabetic recipients, it changed into post-transplant diabetes, and 36% persisted as pre-diabetic, and 42% moved to the normal glycemia. And if we look at the normal glycemia during the first 3 months, here 84% persists to be normal, 13% it changed into pre-diabetes, and this fraction moves to the diabetes. So there is always evolution, and this states the value of oral glucose tolerance test to be used before and after transplantation to know the evolution of these scenarios. One of the important sectors in this presentation is studying the risk factors and assessing risk factors for the development of post-transplant diabetes. Why? Because if we know the risk factors and we can modify them, because risk factors are either modifiable or non-modifiable. So I like to know the modifiable risk factors, because if we know them and we can modify them, this may be translated into better outcome and reduction of post-transplant diabetes. To start with, to investigate the impact of kidney transplantation on insulin sensitivity affecting glucose metabolism, 9 non-diabetic patients awaiting living donor kidney transplantation were examined prior to transplantation with an oral glucose tolerance test and 3-hour hyperinsulinemic euglycemic clamp. The clamp was repeated 6 months after kidney transplantation. And this study, although it included a few number of patients, 9 patients, showed that insulin sensitivity is reduced 6 months after kidney transplantation, and characterized mainly by impaired suppression of endogenous glucose production. So kidney transplantation per se reduces insulin sensitivity. And this is the main issue, impaired suppression of endogenous glucose production. Another risk factor, which is polycystic kidney disease, autosomal dominant polycystic kidney disease, as shown in this systematic review and meta-analysis that included 12 cohort studies, including 1,379 patients with renal failure due to autosomal dominant polycystic kidney disease. The presence of autosomal dominant polycystic kidney disease as an original kidney disease increases the risk of development of post-transplant diabetes, as you see here in this forest plot. and this is the bold relative risks for development of post-transplant diabetes because of autosomal dominant polycystic kidney disease. So the presence of autosomal dominant polycystic kidney disease increases the risk by twofolds, approximate twofolds after transplantation. This is a very important question. Is new onset diabetes after kidney transplantation associated with autosomal dominant polycystic kidney disease in recipients of kidney transplants? This is a very interesting question. Why autosomal dominant polycystic kidney disease is a risk factor for post-transplant diabetes? It may be due to the presence of cysts in the pancreas, because it was described only in 9% of patients. But the majority of autosomal dominant polycystic kidney disease patients with newly diagnosed diabetes after transplantation had no pancreatic cysts. A study on a small sample of patients reported significantly higher insulin resistance in patients with autosomal dominant polycystic kidney disease compared with normal subjects, although their renal function remained normal. Mutations in genes implicated in autosomal dominant polycystic kidney disease could be involved in the mechanism of insulin resistance. So this is the proposed mechanisms of increasing the risk of diabetes because of polycystic kidney disease. Again, either because of the presence of pancreatic cysts, and it is a minority, and the majority are due to the presence of insulin resistance, and this may be because of the gene mutation in the autosomal dominant polycystic kidney disease may lead to insulin resistance. Another risk factor, which is the body mass index. Presence of obesity is bad. The higher the body mass index above 35, as you see here, the higher the percentage of diabetes, post-transplant diabetes, within 1 year among cadaveric kidney transplantation, according to the United States Renal Data System. Let us go to the immune suppressive role in evolution of diabetes and in development of post-transplant diabetes. Before I'm going to saying the role of immune suppression, we have two phases of immune suppression, either induction or maintenance. The induction immune suppression drugs included either interleukin-2 receptor antagonists, which is in this color code, or T-cell depleting, usually thymoglobulin or anti-thymocyte globulin, or others antibodies, and or no induction at all. Let us to discuss the issue of induction and the development of post-transplant diabetes. Basiliximab, which is monoclonal antibodies against CD25 interleukin-2 receptor alpha component. Here, this study included 264 renal transplant recipients. If you look here, there is a significant increase in development of post-transplant diabetes because of the use of Basiliximab in induction therapy. And here the odds ratio is 1.8 because in univariate and 1.9 in multivariate, and this is again a statistically significant association of Basiliximab with newly diagnosed diabetes after transplantation. Another study included larger number of patients, 439, discussing the issue: is Basiliximab induction a novel risk factor for new onset diabetes after transplantation for living donor renal graft recipients? Again, if you look here, this is the data showing here the odds ratio of using interleukin-2 receptor blocker is 2.3, so it is significant value of association of Basiliximab with the occurrence of post-transplant diabetes based on an observational study, including this number of recipients undergoing renal transplantation in a single center. Use of Basiliximab was shown to be a risk factor for new onset diabetes after transplantation. Residual confounding is a concern, but the observation is worth exploration and further attention. The question is why Basiliximab is a risk factor for diabetes. It may be due to that Basiliximab affect the population of T regulatory cells because it inhibits CD25. So inhibiting CD25 affecting the population of T lymphocytes and the regulatory T cells. Basiliximab also indirectly affects pancreatic B cell function and glucose homeostasis. Additionally, administration of interleukin-2 agonist has prevented diabetes in experimental study. This is the data regarding the Basiliximab. What about ATG? This is the most recent systematic review about the use of polyclonal and monoclonal antibodies for induction therapy in kidney transplant recipient. The use of anti-thymocyte globulin had uncertain effects on new onset diabetes after transplantation. So this is regarding the issue of induction therapy. What about the maintenance therapy? This is the calcineurin inhibitor, immune suppressive drugs. If you look here, by the years, cyclosporin is vanishing in renal transplantation, and the majority of renal transplant recipients are maintained with tacrolimus or tacrolimus. Tacrolimus is diabetogenic, and cyclosporin is diabetogenic as well. It seems that tacrolimus is more diabetogenic than cyclosporin. And this is the antiproliferative azacitidine and the mycophenolate mofetil. The majority of patients are currently maintained on mycophenolate. Fortunately, mycophenolate is not associated with development of diabetes. mTOR inhibitors, including sirolimus and everolimus, their use in transplantation at time of transplantation or after 1 year is still limited to this percentage of patients, but the use of this class of drug is diabetogenic as well. Steroid is diabetogenic, and this is the percentage of patients who are treated with steroid. So steroid is still used in approximately 2/3 of adults, and this is the situation in pediatric kidney transplantation. Again, maintenance immune suppression may include steroid, it is diabetogenic, calcineurin inhibitors, diabetogenic, mTOR inhibitor, diabetogenic, or azacitidine or mycophenolate mofetil, they are not diabetogenic. This cartoon shows how calcineurin inhibitors and sirolimus adversely affect the mechanism of insulin. So insulin binds to this receptor, calcineurin inhibitor inhibit this element, and sirolimus inhibit many pathways in the insulin action. This is the most recent article discussing the role of mammalian target of rapamycin in mTOR and the cardiovascular disease and concentrating on diabetes. So the use of mTOR inhibitors like sirolimus or everolimus inhibit the cascade of action of insulin, or even here to inhibit the proinsulin. So this is the main mechanism of diabetogenic mechanism of this class of drugs. To summarize the immune suppressive drug, calcineurin inhibitors, mainly tacrolimus and cyclosporin, reduce insulin secretion, increase insulin resistance, decrease tissue glucose uptake. So this is the diabetogenic mechanism of calcineurin inhibitors. Regarding mTOR inhibitors, it suppresses pancreas B cell response and GLUT1 synthesis. Corticosteroids increases insulin resistance, increases hepatic glucose production, decreases pancreas insulin secretion, and increasing adipose tissue lipolysis. So these are the mechanisms of diabetogenic potential of different immune suppressive drugs. Let us go to Japan. Even in Japan, using tacrolimus, especially if it is used in a high trough level, is associated with increasing the percentage of development of new diabetes after transplantation. And if you look here, the low tacrolimus without MMF, and this is the low tacrolimus with MMF, it seems that the use of mycophenolate mofetil is even protective against diabetes according to this study. Here the high trough level of tacrolimus was the level that exceed 12 nanogram per ml in the twice daily formulation, or 10.5 nanogram per ml in once daily formulation. So this is interesting point to be considered. Even in experimental animal work, this is very interesting. Although it's experimental on rat, but it is very interesting. Here, the experimental design, after acclimatization and a low salt diet for a week, weight matched rats were randomized to 6 groups containing 12 rats each and were treated daily with tacrolimus 1.5 milligram per kg subcutaneous or fecal olive oil 0.3 ml per subcutaneous for 3 weeks. After confirming development of TAC-induced diabetes, empagliflozin either 5 or 10 milligram per kg oral gavage was added for 3 weeks or more. Control rats were treated with empagliflozin only. The dose and duration of treatment was chosen based on previous report of this experience. Additional study was performed to evaluate the early effect of empagliflozin on tacrolimus-induced renal dysfunction by adding empagliflozin to tacrolimus for 1 week. Tacrolimus induced a 2-fold increase in sodium glucose cotransporter 2 expression, while empagliflozin decreased the sodium glucose cotransporter 2 expression and further increased urinary glucose excretion compared to tacrolimus rat groups. And if we look at the result, the empagliflozin reduced hyperglycemia and increased the plasma insulin level, pancreatic islet size, and glucose stimulated insulin secretion compared to the tacrolimus group. And if you look here, in comparison to fecal, this is the islet size. If you compare, islet size is reduced in the tacrolimus group, and the use of empagliflozin ameliorated this reduction if when empagliflozin either in 5 milligram or 10 milligram is added to tacrolimus group. And you can see here, this is a pancreatic side in the fecal treated with empagliflozin, fecal with empagliflozin 10, so the pancreatic size, islet size is preserved. Here the use of tacrolimus reduces significantly the size of islets that is ameliorated by the use of empagliflozin. And this is the insulin mRNA expression. You can find here tacrolimus reduces its expression, and it was ameliorated by the use of empagliflozin. Again, insulin level in the media. If the fecal is used, the insulin level is adequate, but it is drastically reduced by the use of tacrolimus, and this was ameliorated by the use of empagliflozin. Again, even studying apoptosis, as you see, is affected. So the caspasis positive area in islets here in the fecal is lower level of caspasis, but it is very high in the tacrolimus group. That is ameliorated partially by the use of empagliflozin. So this experimental study gave a depth in the information about the hazards of tacrolimus. Regarding steroid is diabetogenic, but this is a very interesting and fantastic study addressing the issue of new onset diabetes after transplantation in a double-blind early corticosteroid withdrawal trial. And in this study, this was prospective randomized trial of corticosteroid withdrawal, indicate that corticosteroid withdrawal has a limited impact in reducing new onset diabetes after transplantation when compared to low dose prednisone 5 milligram per day from a month 6 to 5 years. So it seemed that using very small dose of steroid, prednisolone 5 milligram, is satisfactory with lower side effects. So it's better to weight the risk and the benefits, because if we stop steroid, this may increase the risk of rejection. So we should evaluate the immunological risk before considering withdrawal of steroid, because this study gave a good evidence that using 5 milligram prednisone daily is associated with lower adverse events, and it seemed that it is not harmful regarding diabetes. This is another study addressing the same issues. Strategies of 6 to 12 months steroid withdrawal post-kidney transplantation are expected in this study, that including this is steroid avoidance, is early steroid withdrawal at 6 months, at 12 months, versus steroid maintenance, and this is the number of patients. Here, it seems that steroid of 6 and 12 months steroid withdrawal, strategies of steroid withdrawal at 6 and 12 months are expected to reduce the rates of adverse cardiovascular events and other outcomes with no worsening of acute rejection or graft loss rate compared with steroid maintenance. Again, this is steroid protocol incidence of post-transplant diabetes in the de novo kidney transplant recipients receiving prolonged release tacrolimus-based immunosuppression with two different corticosteroid minimization protocol. Here, this is the study. The prolonged release, this is the protocol. All patients received prolonged release tacrolimus, Basiliximab, MMF, and one bolus of intraoperative corticosteroid. Arm 1 received tapered corticosteroid, stopped after 10 days, whereas patient in Arm 2 received no steroid after the intraoperative bolus. And in this study, a prolonged release tacrolimus, Basiliximab, MMF immune suppressive regimen is effective with a low incidence of post-transplant diabetes. This is the development of post-transplant diabetes in both arms of steroid minimization, either tapered over 10 days or not given after the bolus in these patients. However, I am stressing on the rationale of avoiding withdrawal of steroid in patients with high risk, high immunological risk. So should weight the risk and benefits to select the best protocol for our patients. Again, here this is the impact of rejection. So rejection, acute rejection is usually treated with pulse steroids. So the using antirejection therapy in this number of recipients, this is the total number of studied recipients, and the rejection, when rejection occurred, it was treated with steroid. So using high pulse steroid for treating rejection for those who develop the rejection increases the relative risk of post-transplant diabetes by 3.5. So it increases this by 3.5-fold. So this is the sector of immune suppression and its relation to diabetes. What about the visceral obesity, visceral fat? Visceral fat is strongly associated with post-transplant diabetes mellitus and glucose metabolism 1 year after kidney transplantation. Here, glycemic state was assessed by oral glucose tolerance, and the fat was assessed by DEXA scan. So it seems that visceral fat is superior to body mass index in telling the risk for diabetes. Even development of inpatient hyperglycemia is bad news, because new onset diabetes after transplantation occurred in 4% of those patients who had no inpatient hyperglycemia, in comparison to 30% of patients who developed the inpatient hyperglycemia. So we should follow up these patients by concentrating on their follow-up. And if these patients who developed inpatient hyperglycemia require the insulin, the relative risk of new onset diabetes increased 4-fold. So it is better to know the history, the follow-up of patient. Is there a period of inpatient hyperglycemia? Is this inpatient hyperglycemia necessitated insulin? Because the presence of inpatient hyperglycemia is bad news, and if this hyperglycemia necessitated insulin, this increases the risk of development of diabetes more and more. Regarding the presence of pre-diabetes as diagnosed by hemoglobin A1C between 5.7 to 6.4%, the presence of this level of pre-diabetes increases post-transplant diabetes by 4.5-fold. Again, this is the situation, as I mentioned, that there is evolution of pre-diabetes toward diabetes, so it is better to look at the glycemic follow-up. Adiponectin adiponectin is present in either high or low molecular weight. So adiponectin is mainly produced and subsequently secreted by adipocyte in white and brown adipocyte tissues. This is here we should think of high. If high, a previous study reported that its high molecular weight levels were closely associated with the prevention of coronary arterial disease, weight loss effects, and improved insulin resistance. So if we think of risk factors regarding adiponectin, we will find lower high molecular weight fraction and higher low molecular weight 1. So this is a Japanese study. Even in Japanese renal transplant recipient, visceral fat area and adiponectin fractions were significant factor for the development of both cardiovascular disease and post-transplant diabetes. The visceral fat area was inversely correlated with serum high molecular weight adiponectin. Furthermore, the visceral fat area was positively correlated with low molecular weight adiponectin ratio. So this is maybe a link between obesity and development of diabetes. There's another study showing that inflammation at the time of transplantation prior to kidney transplantation may increase the risk of post-transplant diabetes. Here, studying 36 controls and 32 transplant patients, of whom 11% developed post-transplant diabetes, compared to control plasma TNF-alpha, interleukin-6, MCP1, and C-reactive protein levels were higher in transplant patients. And in multivariate analysis, TNF-alpha plasma level before transplantation were associated with development of post-transplant diabetes, and the odds ratio is 2.03. This means that TNF-alpha could contribute to post-transplant diabetes through an effect on adiponectin. This study proposes that inflammation is involved in glucose regulation after kidney transplantation. The issue of serum magnesium is hypomagnesemia a risk for development of post-transplant diabetes. So this is one of the studies showing the link of hypomagnesemia with development of diabetes. Hypomagnesemia before transplantation can become more pronounced after transplantation because of the use of calcineurin inhibitors, diuretics, and the presence of renal tubular dysfunction after kidney transplantation. The presence of hypomagnesemia accelerate the development of newly diagnosed diabetes after transplantation. So hypomagnesemia before and after transplantation are considered risk factors for development of diabetes. Serum magnesium level should be closely monitored. Magnesium is essential for beta cell function. It acts on cellular glucose transport and pancreatic insulin secretion, and it's involved in the post-receptor insulin signaling. This is why hypomagnesemia induces insulin resistance and may modulate insulin action and sensitivity, leading to diabetes onset. So this is very important. The incidence of hypomagnesemia is high among patients with type 2 diabetes. Hypomagnesemia is common finding, especially in the early post-transplantation period, and is particularly correlated with the use of calcineurin inhibitors, including cyclosporin and tacrolimus. So we should think of other non-traditional risk factors like serum magnesium. Again, this is a study in pediatric renal transplant recipient, including 173 patients. Hypomagnesemia increased the risk of new onset diabetes after transplantation. And the association between hypomagnesemia and new onset diabetes may not be causal. Both hypomagnesemia and diabetes can result from mitochondrial dysfunction, as found in a large pedigree with hypomagnesemia and the metabolic syndrome. So all these ideas should be put in mind when we think of risk factors. A larger study, including this systematic review and meta-analysis, including 5 cohort studies, including 1,690 cases, linked hypomagnesemia with the development of diabetes after kidney transplantation. So this is another important point. Even in Saudi population, including 500 renal transplant recipients, these are the risk factors for development of diabetes, including old age, family history of diabetes, hepatitis C and virus infection, impaired fasting glucose. So this is all these are all these are risk factors for development of diabetes. Regarding hepatitis C virus, this is one of old studies. This was meta-analysis of clinical studies, included 10 studies involving 2,500 renal transplant recipients, showed that hepatitis C is associated with development of diabetes. The odds ratio for development of diabetes because of HCV is 3.9, and the confidence interval ranged from 1.8 to 8.6. So again, hepatitis C is a risk factor for development of diabetes. And when we review the literature, you can find, this is one of the interesting articles, current level of evidence on causal association between hepatitis C virus and type 2 diabetes. This is a review, and this is the this figure illustrates the mechanisms beyond this association. So hepatitis C leads to chronic inflammation, leads to insulin resistance, lead to cardiovascular risk factors. So this is the correlation of the hepatitis C with diabetes. The patients may have candidate genes for post-transplant diabetes susceptibility, and this slide shows a lot of these candidate genes, so and its genotype and polymorphism. To summarize all what I addressed in the sector of risk factors, we can look at a glance. A risk factor for post-transplant diabetes include either pre-existing diabetic risk, age above 40, body mass index above 25 kg per square meter, specific race, ethnicity, positive family history of diabetes, the presence of diabetic mellitus candidate genes, pre-diabetes, metabolic syndrome, particularly lower HDL. So all these are pre-existing diabetic risk. The use of immune suppressants drugs, and I discussed the role of calcineurin inhibitors, corticosteroids, and mTOR inhibitors. The presence of inflammation, like the presence of hepatitis C, cytomegalovirus, HLA mismatch, disease donor rejection, all these are inflammatory environment that increases the risk of post-transplant diabetes. And the other risk factors, including polycystic kidney disease in kidney as original kidney disease, use of statin maybe, but if we should be careful, because use of statin is crucial to reduce cardiovascular risk factors, hypovitaminous D, and hypomagnesemia. So this slide summarizes all the risk factors for post-transplant diabetes at a glance. And again, these are the risk factors, and the main mechanism and the pathogenetic proposed mechanisms are through impaired beta cell secretory capacity or increasing insulin resistance at the end. This will lead to impaired glucose tolerance and new diabetes after kidney transplantation. So what about the management? The management depends upon the onset. So if we diagnose hyperglycemia, here we agreed that if hyperglycemia is in this zone in the first 6 weeks, it is hyperglycemia, not diabetes. So if we diagnose hyperglycemia in the first week, the treatment is insulin exclusively. Between 8 to 45 days, insulin and oral anti-hyperglycemic agents. If it's beyond this time interval, lifestyle, oral and diabetic, and use insulin like the treatment of type 2 diabetes. Regarding the role of diet, the diet is important because the degree to which the consumed diet resembles the traditional Mediterranean diet was calculated according to this is interesting data because it looked at the Mediterranean style diet. So 9 points of Mediterranean diet score. The score include 9 food groups, ratio of monosaturated to saturated fatty acids, intake of legumes, cereals, vegetables, fruit, fish, dairy products, meat products, and alcohol. Food items were divided over these 9 food groups. For each food group, the 6 specific median in grams per day was used as cutoff point for making this division, except for fish and alcohol. Patient received a score of 1 for each of the protective component, ratio of mono unsaturated to saturated, legumes, cereals, vegetable, fruit, if their intake was above the median. The traditional Mediterranean diet was low in dairy and meat products, therefore an intake below the median for this food group was scored 1, and for intake above the median 1 for the fish component. Participants received a score 1 if they consumed more than 5 grams per day, and a score of 0 if they consumed less than 5 grams per day, less than 1 month. Alcohol users received a score of 1, and non-user received a score 0. Moderate alcohol intake is associated with low prevalence of new onset diabetes and lower risk for mortality, according to this publication, compared to abstinence. Subsequently, all patients were divided into 2 groups based on frequency distribution of this scoring system. Group 1 between 0 to 4 and group 2 between 5 to 9, and they were dichomatized, and this is the result for men and women according to the 9 component ratio of unsaturated to saturated, legumes, nuts and soy products, cereals, fruit, vegetables, meat products, dairy products, fish, and alcohol. This is for men, and this is for women, 0 to 4 and 5 to 9. This is the diet. So the diet is important, and we should follow the healthy diet by using the best strategy for diet advice. So first month after transplantation, glycemic target is fasting glucose less than 7 millimole, postprandial less than 10 millimole, treatment by insulin, dietary advice, and encourage physical activity. Maintenance treatment is glycemic target of less than 7 millimole fasting glucose, less than 10 millimole postprandial glucose, 7.5 to 8% hemoglobin A1C, and the treatment, dietary advice, encourage physical activity, continue insulin or initiate oral glucose lowering agent, taper prednisolone if possible to 5 milligram per day, trough tacrolimus to be between 3 to 0.7 if permitted by the immunological risk assessment. Recommended hypoglycemic agent using DPP-4 inhibitors, glimepiride, glipizide, nataglinide or ribaglinide, metformin if GFR is above 60 ml per minute. Hypoglycemic agents still require studying in post-transplant diabetes are GLP-1 analog, sodium glucose cotransporter inhibitor, metformin in the presence of lower GFR. So this is an interesting point, because here this table is very important because it shows the different drugs used in management of the patients, so using the different classes. If we look at the first generation sulfonylurea, should be avoided because they have many interactions. Second generation sulfonylurea like glipizide and glipizide can be used, but they may increase cyclosporin level. The glucagon can be used. Glipizide, avoid if its GFR is less than 50 ml per minute, and it may increase as well cyclosporin level. Glimepiride start with 1 milligram per day, and it may increase cyclosporin level. The metformin, avoid if its GFR is reduced. The alpha glucosidase inhibitor, avoid if GFR is less than 30 ml per minute. Meglitinide, ribaglinide, cautious titration, start by 0.5 milligram if GFR is less than 40. Increase level of ribaglinide with cyclosporin. So this is interesting interactions. Nataglinide, cautious use if GFR is less than 60 ml per minute, and increases level of nataglinide with cyclosporin. So cyclosporin increases the risk of hypoglycemia if we use meglitinides. Bioglitz zone, avoid if there is heart failure. Incretin mimetics like xanthine, avoid if GFR is less than 30 milli per minute. DPP-4 inhibitors, sitagliptin, reduced to 50 milligram if estimate GFR between 50 to 30 milli per minute, to 25 milligram if GFR is less than 30 milli per minute, and it is metabolized by cytochrome system. Vildagliptin, avoid if dialyzed, caution if GFR is less than 60 milli per minute, no interaction with cytochrome system. Saxagliptin, 2.5 milligram daily if GFR less than 50 milli, it is metabolized by cytochrome system. So this is regarding different drugs. Regarding sodium glucose cotransporter 2 inhibitors, still we are waiting further evidence. This is from the Urology and Nephrology Center, drug-drug interaction between immune suppressants and diabetic drugs in the treatment of post-transplant diabetes. This is done by the clinical pharmacy department at Urology and Nephrology Center. Here, if the ribaglinide is used with cyclosporin, the risk of hypoglycemia is there. Rosiglitazone, cyclosporin MMF, it may increase MMF toxicity. Sitagliptin with cyclosporin MMF it may increase cyclosporin toxicity. Glipizide increase cyclosporin toxicity. Glyburide increase cyclosporin toxicity. So we should be cautious by monitoring the drug level and monitoring the glycemic state. Earlier use of basal insulin is fantastic because although this study included few number of patients randomized into 2 treatment groups, if you look at the treatment group with basal insulin, the type 2 diabetes vanished with the end of the first year. This is maybe because the basal insulin is islet protect islet cell, and currently there is ongoing trial to assess this the value of basal insulin. And this is the Cochrane reviewer group systematic review addressing the issue of glucose lowering agent for treating hyperdiabetes after transplantation, and this is evidence. This study showed that the available research concerning glucose lowering treatment for diabetes in people who have received the kidney transplantation is limited. More studies are required to confirm the effectiveness and safety of glucose lowering agent in this population. Conversion of TAC to cyclosporin, although it is done in this study in 10 patients, however, we should weigh the immunological risk, especially in hepatitis C positive patients. Hepatitis C positive patients show significantly improved the glucose stimulated insulin sensitivity and overall glucose tolerance after conversion from tacrolimus to cyclosporin, and considering HCV-induced insulin resistance, HCV positive renal transplant recipient may benefit from cyclosporin A-based immunosuppressive regimen, although again and again it is a limited evidence, and we should evaluate the immunological risk before doing any modification of immunosuppressive drug. Another interesting and exciting study showing that erythropoiesis-stimulating agent exposure may be associated with reduced incidence of new onset diabetes in the post-transplant population. The role of erythropoiesis-stimulating agent in preventing new onset diabetes requires further investigation. Regarding the outcome of hyperglycemia and diabetes after transplantation, this is a post-transplant hyperglycemia, as you see, and the transient post-transplant hyperglycemia. And no, there is insignificant reduction of the graft survival, but here the presence of post-transplant diabetes adversely affect the graft survival. When we look at this large number of cohort of patients in this Norwegian renal transplant study, they looked at the observation time starting at the time of renal transplantation. Here, the presence of diabetes is bad news, increase the hazards for graft loss 1.3-fold. And this is, again, if it is done after 10 weeks of transplantation, the presence of diabetes before transplantation, post-transplant diabetes, impaired glucose tolerance, all these affect the graft survival, but the diabetes before transplantation and post-transplant diabetes are associated with significant adverse effect on graft survival by multivariate adjusted analysis. And after 1 year of transplantation, here if you look, the presence of diabetes before transplantation and development of a new onset diabetes after transplantation or post-transplant diabetes, both of them were associated with impaired graft survival or lowered graft survival. So the presence of diabetes after transplantation is bad news. If the analysis is done after making this sensor, here after 1 year, there is no difference between diabetes and non-diabetic or the development from post-transplant diabetes or not. So it seems that diabetes, either pre-existing or post-transplant diabetes, affect graft survival through increasing patient loss, death. So the main issue is patient death with functioning graft. So this is the points. This is another study showing an interesting data that the correlation of the presence of diabetes either before transplantation or development of post-transplant diabetes, and the correlation of this presence with infection control and alloreactivity. Upon multivariate analysis, age, obesity, and use of tacrolimus increase the risk of post-transplant diabetes, and the kidney transplant recipients with pre-existing diabetes or post-transplant diabetes showed higher rates of sepsis. Total CD3, CD4 T cells count were significantly lower in kidney transplant recipient with post-transplant diabetes or pre-existing diabetes. No difference were observed for CMV specific T cell between any groups. Kidney transplant recipients developing post-transplant diabetes showed increased frequencies of alloreactive T cell post-transplantation. And the conclusion from this study is higher rates of insulin infection in kidney transplant recipients with pre-existing diabetes or post-transplant diabetes is attributed to impaired overall immunity. Higher frequencies of alloreactive T cells contribute to inferior long-term outcomes. Since acute rejection but not pre-existing diabetes, post-transplant diabetes was associated with inferior allograft survival and function. Maintaining adequate immune suppression to prevent rejection seems important. So again and again, there is a correlation between the presence of diabetes either before transplantation or development of diabetes post-transplantation and the impaired infection control and increased alloreactivity. That is very exciting. Regarding our experience at Urology and Nephrology Center, before I'm going to highlight our results regarding the post-transplant diabetes, I want just to say that we are lucky because we worked under supervision of Professor Muhammad Ahmad Wanim, the founder of Urology and Nephrology Center and the leader of renal transplantation, not only in Egypt but also all over the Middle East. He started his journey for renal transplantation in Mansoura on March 1976 within the Mansoura University Hospital. Then moved the service of transplantation to the Urology and Nephrology Center from 1983 until now. The total number of renal transplantation carried out at Mansoura University by Professor Ghunaim and his team is today is 2,827 live donor kidney transplantation, and more than 85% of them is live related kidney transplantation. Regarding post-transplant diabetes, this is one of the publications from the center. Here the cohort of patients included 2,019 recipients. Diabetes developed after transplantation in 450. This 22% of recipients developed new diabetes after kidney transplantation. The risk factors we found: old age, age above 40, positive family history of diabetes, high body mass index, the presence of HCV infection and the hypercholesterolemia. And this is the onset of diabetes mellitus. The majority of them occurred within the first 3 months. And this is the different onset, as you see. This slide summarizes all risk factors. This is the complications of occurrence of post-transplant diabetes, increasing hypertension, hypercholesterolemia, ischemic heart disease, proteinuria, neuropathies, retinopathy. So all these are increased, pancreatitis, bacterial infection, and viral infection, principally HCV. So the presence of diabetes post-transplantation is bad news and associated with many cardiovascular risk factors. This is a biopsy of one of our patients who developed post-transplant diabetes, showing the classic diabetic nephropathy, increased mesangial matrix as shown by these arrows, and the segmental sclerosis, and the presence of hyalinization, nodal hyaline thickening of arterioles. So this is a classic diabetic nephropathy. Although graft survival is not affected by the development of post-transplant diabetes, but patient survival was significantly affected, and it was lower for those who developed diabetes. One of the risk factors that we addressed in our center is circulating serum apelin. Serum apelin suppresses insulin secretion by binding to the G protein coupled apelin receptor on beta cell of islets of Langerhans. So we found a correlation between the serum apelin. So serum apelin has a high level of serum apelin is associated with high risk of post-transplant diabetes. Regarding our protocol in steroid avoidance, this is a long-term study of steroid avoidance in renal transplant recipient. This was very nice because the steroid avoidance is associated with significantly lower risk of post-transplant diabetes and hypertension. So the risk of diabetes is reduced from 15% in patients who were maintained on steroid versus avoiding steroid after the first week of within the first week of transplantation, from 15% to 5% of diabetes. But be aware that all these patients were within low immunological risk, and they were maintained on FK, tacrolimus, and MMF. And again, the outcome is not affected by steroid withdrawal. Graft and patient survival is fine after steroid withdrawal. So this is a successful use of steroid avoidance in renal transplant patients, and showing that steroid avoidance is associated with lower risk of post-transplant diabetes. Again and again and again, these were of low immunological risk. Regarding tacrolimus, as I mentioned before, although it is associated with increasing risk of diabetes, however, it is essential and one of the cornerstone drugs in maintenance immune suppression. Here, according to one of the reports, this is the last report of the factors affecting graft survival that was published by Professor Hussein and others. Here, the use of tacrolimus was associated with the best survival. Here, graft survival 5 years, 90%, and 86% at 10 years for those who use tacrolimus. So instead of thinking of stopping essential drugs, we should learn how to use them using accepted levels. We started to use little bit lower levels in the current era, and instead of using very high levels in the past, we now use the tacrolimus in a dose of 0.1 milligram per kg divided into doses, and aiming for drug trough level of between less than 10 nanogram per ml down to 6 or 7 in the first weeks of transplantation, to be used later between 4 and 6 nanogram per ml. This is a very nice level and is associated with lower side effects. So regarding hepatitis C, this is one of our studies showing that hepatitis C is correlated with post-transplant diabetes. Here post-transplant diabetes occurred in 27% in hepatitis C positive patients in comparison to 19% in non-diabetic, although it was insignificant in this cohort of patients. It was long-term follow-up of these patients, but was retrospective cohort study. But in this cohort of patients, including larger number of patients, the presence of diabetes is significantly higher among the hepatitis C patients. So 85 out of 300 had post-transplant diabetes. Of those who have had positive HCV, and 87 out of 598 of hepatitis C negative patient developed diabetes. Again, hepatitis C in this cohort is significantly associated with diabetes. Regarding donor, this is the last corner in this presentation, and in the kidney donor sector, I'm going to just to highlight the European best practice guidelines, and then how to evaluate the diabetic. Are we going to use diabetic donor as a diabetic person as a kidney donor? And then I'll answer the question, what about the liver live kidney donor diabetes risk? Live donor in the stage kidney risk, because we should look at donor as very precious, because he is voluntarily giving an organ, giving a life gift to the recipients. What about obesity hazards? And I'll end with Mansoura experience. So this is the European best practice guideline. They recommended diabetes is a contraindication to kidney donation. They suggested impaired glucose tolerance is not an absolute contraindication to donation. But if there is impaired glucose tolerance plus obesity, this is a contraindication. And here they suggest body mass index above 35 kilogram per square meter is a contraindication to the donation. And they recommend counseling obese and overweight donors for weight loss before and after donation. And after donation is very important, because sometimes we advise them to for weight reduction before donation, and after they donated their kidneys, they gain weight, and gaining weight is bad, as I will mention in the sector of obesity. Regarding donors, in cadaveric organ transplantation, we can use kidneys from diabetic persons, and this is the overall allograft half-life for non-diabetic versus diabetic donors. So overall, this is allograft half-life 9 years. If we use the kidney donor from non-diabetic donors, this is the half-life, but half-life is affected and reduced by using the diabetic donors. And this is a combination of non-diabetic donor and non-diabetic recipient. This achieves the best allograft half-life. This non-diabetic donor to diabetic recipient, so the presence of diabetes in recipient also affects the outcome. Diabetic donor and non-diabetic recipient, this is the half-life, but the worst combination is, and this is bad, diabetic donor for diabetic recipient. So again, in cadaveric donor, we can use kidneys from a diabetic individual so long as the kidney is accepted in function. However, we can look at the half-life here and know that the use of donors, the kidneys from a diabetic person, has a lower survival. And this is a Kaplan-Meier curve showing the best survival is for those non-diabetic kidney donor to non-diabetic recipient, and the lowest survival is for those diabetic donor to diabetic recipient. So this is in a cadaveric and accepted. But in live donor kidney transplantation, as the European best practice guidelines stated, that diabetes is considered a contraindication for donation. This is from Japan. A live donor were evaluated by oral glucose tolerance. So for these four live donors, 373 had normoglycemia, and 27 were diabetic, and 44 had impaired glucose tolerance and accepted to be donors. But it is of minor evidence, low evidence, and the evidence is to avoid taking kidney from diabetic person in a living kidney donation. So what about the live donor diabetes risk? If the person donated his kidney, is there a risk for the development of diabetes? This is a very interesting data here. If there is obesity here, if we compare those who achieve the normal body weight all through after kidney donation, the risk of diabetes is 1.2%, and here 2.8% if they had overweight. But if they develop diabetes, the risk of diabetes increased after development of obesity after kidney donation to 12%, and this is a very significant level. Again, the risk factors for post-donation diabetes in this cohort of patients include 3,900 patients, including older age. The significant here, body mass index again and again, the higher body mass index is associated with increasing risk of diabetes and as well as smoking. So we should educate donors after kidney donation not to gain weight. They should manipulate their diet to avoid weight gain and to avoid smoking, because smoking is a kidney poison and is associated with cardiovascular risk factor, and here it increases the risk factor for development of diabetes. A very interesting data for me when I read this article, because I didn't imagine that there is live pancreas donor, so it is very rare to be used in live pancreas donor, and the live pancreas donor is associated with significantly higher post-donation diabetes in comparison to kidney donor. So diabetes is more common after living pancreas donation than living kidney donation, and supporting clinical consequence from reducing endocrine reserve. Again, we should think of better lifestyle for our live kidney donor. What about live donor interstitial disease development? This is one of the studies, including 125,000 donors from United States, showing the patterns of interstitial disease caused by diabetes, hypertension, and other causes. And here, if we look at the data, the presence of diabetes, development of diabetes after kidney donation is bad news, because it increases the risk of development of end-stage kidney disease beyond 10 years to 25 years. So late diabetes is associated with late development of end-stage kidney disease, and this is present all through the different demographic criteria. So we should think of avoiding development of diabetes after kidney donation, and the best way is to avoid weight gain. This is in white kidney donors, 3,900. The post-donation diabetes and hypertension is associated with a 4-fold higher risk of proteinuria and a 2-fold higher risk of end-stage disease. This is the risk of end-stage kidney disease after live kidney donation. In this number of donors, 96,000 live kidney donors, and this is in the general population, 4,933,000 individuals and 52,000 donors. And after evaluating all this data, there is a very smart tool for predicting end-stage disease, just to apply in this calculator by putting the age, gender, race, estimate GFR, systolic blood pressure, hypertension medication, body mass index, non-insulin dependent diabetes, urine albumin creatinine ratio, smoking history. If you put all these data, and this is the data of the patient, you'll find the 15 years projected incidence of end-stage kidney disease is 0.6%, and the pre-donation and the lifetime is 2.4%. Regarding body mass index, if we in this another calculator, if we put this is male, non-African American, age 25 years, body mass index is 23, and donor degree is this is all the data. If the data is like this is the risk for development of end-stage kidney disease per 10,000. So if you look here for 20 years, the risk is 25 per 10,000 through this after 20 years. But if you use the same data for everything except body mass index, here is changed from 23 to 34. The risk increased from 25 per 10,000 to 70 of 10,000. So again and again, the obesity is bad, and we should combat obesity in live kidney donors. Long-term follow-up after live kidney donation, this is a protocol, longitudinal prospective study, and we are waiting the result of this study. And this is a very interesting study looking at the solitary kidney, the effect of diabetes, and this study showed a higher value of proteinuria due to phenomena of hypertrophy and hyperfiltration in the study group in diabetic solitary kidney, so significantly higher metabolic abnormalities, glycemia, triglyceridemia, hyperuricemia, as well as higher prevalence of arterial hypertension and coronary artery disease are associated with diabetes. There was no difference in the glomerular filtration rate between two groups. As such, the supposition of the phenomena of hypertrophy and hyperfiltration of the solitary kidney and diabetes couldn't be proven. Patients with single kidney and diabetes should be carefully monitored from nephrological viewpoint for proteinuria, GFR, and arterial hypertension and the cardiovascular disease. Again and again, if even the evidence is not strong, we should follow these persons to avoid the development of diabetes. Regarding obesity, this is the obese donor, non-obese donors, and this large number of donors. Here, the risk of end stage increased through the years. Here, if the obese, after 5 years, 3.2, 15.2 per 10,000, and here 42.5, and this is 90 versus 39. So this is after 10 years. So this is a cumulative incidence of end-stage kidney disease per 10,000 live donor, estimated with multiple input, and this is a curve of obese and non-obese. So we should do our best to avoid obesity in kidney donation. After kidney donation, setting the limit for living kidney donation, how big is too big. So we should avoid obesity, because obesity is bad, associated with inflammatory environment that can affect adversely the kidney and leads to interstitial pathology and interstitial fibrosis, and the metabolic disease constitute the main cause of donor exclusion. This is a study that addressed the exclusion criteria. Again and again and again, we are stressing upon this issue. We should avoid accepting the obese donor to donate, diabetic donor to donate, donor with live kidney donors with embedded glucose tolerance to donate, because this will put them in a risk for cardiovascular and end-stage kidney disease. Regarding our experience in neurology and referral center, this study included 388 donors to study the risk of development of diabetes, glycemic control after donation, impaired fasting and impaired glucose tolerance in 15%, and diabetes developed in 11% of these persons. The risk factors for post-donation diabetes included positive family history and body mass index above 30 kilogram per square meter. And this is the data regarding the different body mass index and the frequency of diabetes among studied donors. So body mass index above 30 is associated with increasing risk of development of diabetes after kidney donation. And even this is the end-stage renal disease among our cohort of kidney donor, 8 out of 2,000, and 3 of the 8 who developed the end-stage kidney disease after kidney donation had diabetes. So we should, even if this is like the general population, we should combat the development of diabetes and obesity. This is one of the old journey of diabetes, and this is the stamp issued by Egypt in 1971 for the World Health Organization's World Health Day. The stamp features a section of the Ebers papyrus and the portrait of the Egyptian physician history. This papyrus paper documented that ancient Egyptian 3,000 year BC knew well how to manage the disease of increased urine, because at that time diabetes as a name was not known, but they knew it under the name of the disease of excess urine. So we should resume our potentialities to improve our thinking and doing better research for refinement of our practice. At the end, this is the quotation of Mahatma Gandhi: live as if you were to die tomorrow, and learn as if you were to live forever. So we should continue learning till the end. Thank you very much, and I'll be happy if you have any questions. Thank you.